Well, awesome. Thank you guys for joining us.
Thank you.
I'm Sahar Bedrood. I'm from Los Angeles, California, a cataract and glaucoma specialist. And this is Bill Wiley. I'll let him introduce himself.
Yeah, Bill Wiley from Cleveland, Ohio with Cleveland Eye Clinic and MVP, cataract and refractive and MIG surgeon.
And everything, the whole
yeah,
thing,
right.
You know?
The whole gamut.
Yeah, that's right. That's awesome.
Yeah.
We're going to talk a little bit about canaloplasty and iTrack Advance. We both have had some experience with it and wanted to share our own experiences and share some videos as well.
Yeah, it's been a great product. It's, in the MIG space, it's the product I'm most excited about. It's just, just started using it, and it's, so many nuances about it, but having that visibility, that 360 degree, you can see the immediate action. It's been a great tool.
Yes.
And the efficacy has been awesome. So there's so many, it's so well thought out, so well designed, and excited to be a part of this technology and talking about it with you.
Yeah, I agree with you. We will go through a lot of it together, but that really stands out. I'm also a newer adopter of the technology, so I think that helps to kind of identify that, because we all have to use new technology, new innovation, and discover what works for us. So let's get started. So I think the one thing that we wanted to talk about first is the catheterization. So the actual using the catheter with a guide wire, with the light at the end, and allowing it to expand the whole canal 360. So there's two components. One is catheterization and one is viscodilation.
Yes.
Right? So catheterization, I wanted to talk to you because I had a comparison made of the canal compared to like the esophagus.
Yes.
Where the canal is flattened and we need something to actually open it up.
That's
and
right.
That catheter with a guide wire allows you to go 360.
Yes.
And it is really, really nice to see the red light. So you know exactly where you are in the process.
Yes.
And I think that is one of the things that stands out. In terms of that experience for you, how would you talk about that?
Yeah, I totally agree. I think what's interesting with other devices, as soon as I would go outside the view of the gonium mirror, I would get anxious because I didn't know where that device is going. Let's say if it's going posterior or maybe going down a collector channel, causing damage. I've had situations where I've caused, let's say, cyclodialysis or iridodialysis because maybe the device is pushing something that you didn't know and you didn't know to stop. With this, you get visualization 360 degrees, so you're watching it the whole way, and it gives a surgeon comfort.
Yes.
You're in the right spot. What's also great is that controlled visco delivery.
Yes.
As you're inserting it, you can have that visco applied to open up the pathway as that catheter is advancing.
Right. That's
and
right.
So if you get an obstruction, you can back up, deliver some viscoelastic, open up that obstruction, and so it's amazing just to see, have that ability at your fingertips. And I don't know what your thoughts were, but having somebody else control the viscoelastic delivery, I thought was an advantage.
Yes.
Because you have the ability to just sort of count it out.
Yes.
While you have both your hands on the surgery, you get somebody else delivering the viscoelastic as you need it.
Yeah, exactly. And so I think that actually takes us to the next one, which is viscodilation.
Yes.
And part of it is the catheter opens up the canal.
Yes.
And then the second part of this is the delivery of the viscoelastic.
That's right.
To as you're, we'll show surgical videos, but the delivery of the viscoelastic is in 100 microliters, which is a large amount, and allows it to kind of open everything up.
That's right.
In a really controlled fashion.
Yes.
And I think that one of the things that I really enjoyed while I was doing this is the first few cases I noticed, gosh, that limbus is turning really nice and white.
Yes.
And all those vessels that are really, really bright just blanch. And it's an opportunity, you see, to access things, an area that hasn't been accessed in a long time.
Yes. No, I totally agree. I think having that immediate feedback of seeing the blanching, you can actually see the blood vessels blanch right there as you're advancing or as you're injecting viscoelastic. And to see that, you're causing an immediate effect.
Yeah.
You feel confident that you've done something to help the disease.
Yes.
And I've never seen a device have that that ability. Maybe you would once in a while see blanching and something else, but this is every single time.
That's right.
Yeah.
That's right. If you saw it, it was like, oh, did you catch it on video?
Yeah,
because I didn't see that all the other times.
That's right.
But in this case, I'm like, oh gosh, it's every time this happens.
Yes.
So that part's really nice.
Yeah, it's cool.
All right. So here we have a video. I'm just going to kind of take you guys through this. I'll start with this video. Maybe you can handle the next one. This is pulsing. You can actually see, so you identify the catheter. Always try to prime it. I asked the scrub tech to always use 3 or 4 clicks to get to make sure that everything is coming out smoothly before you're doing this inside the anterior chamber. You put the lens onto the eye and get a view similar to when you do any other angle surgery. You do have to have that side paracentesis in order, and here he notes a little bit of blood. He's pointing out his own mistake because Paul's so critical, right, of himself. But so you really want a clearer view. You see the tip of that, the light, and the beauty is you got to see it coming around, and you see it coming all the way around. It disappears at times in between the edges of the gonioscope, and then you see it at the edge come right back to where you started. And that's when you ask your scrub tech to do the clicks. And you do 1, 2, 3 clicks, and then you slowly bring it back. Every clock hour that you bring back, there's another click.
That's right.
And then slowly, and this part is really nice and beautifully slow, slower than we're used to, right? But that slow delivery allows for like the adequate viscodilation.
And there you can see the blanching.
Yeah.
Immediate effect.
Yeah, absolutely. You see it right there. And that's a subtle one. I think in my experience, it has been a little more dramatic than that. I think I have a couple of videos that show that.
Yeah, I would agree.
And then you come out and you clean the viscoelastic as you normally would. So this concept that when you are viscodilating and allowing this kind of pressurized, it's like pressurized cleaning.
Yeah.
And when you do that, it removes some of the debris.
Yes.
Have you noticed that in any of your cases?
Yeah. What's interesting, we did a case where I put blue stain in the viscoelastic.
Oh, nice.
Vision Blue and Trypan. And then as what was interesting, as we're injecting the viscoelastic, you saw the blue do 2 things. Number one, you could see it track down the collector channel, so you knew it was active there, but you also saw it kind of leaking or blowing into the anterior chamber. And so that effect, it was 360 degrees. So you're sort of like blowing open the trabecular meshwork, kind of cleaning the debris out of the trabecular meshwork. It was that immediate feedback I said, because without the stain, I wasn't really sure what was happening, but having that stain, you can see it acting in both directions, both like downstream, but also upstream.
That is interesting. See, I did not expect a reflux of debris, and since that is usually not something we pick up on, it's so microscopic, but being able to stain it, you were able to do that, and people have talked about it at other discussions that I've seen. So I think that there's something to that. There's a lot about that angle that we don't know. It's flattened, it's collapsed, and then post viscodilation, you can see that things are kind of more expanded out. And there's this theory that whole part of the angle is functional.
That's right.
It is actually pumping things from inside across. So being able to rejuvenate it rather than like rip it out, I think is, or not ever use it at all, I think is advantageous.
Yeah, no, I agree. I think in my approach, if I can save the anatomy for other future devices, so let's say, to be destructive and remove trabecular meshwork out of the gate, I think is problematic because you don't know what long-term scarring that might entail, and you also leave something in your back pocket for future intervention. There's a lot of stents on the market or drug-eluting stents, and to remove the trabecular meshwork, I think can be a little bit problematic. So out of the gates, if you have the ability to rejuvenate it, like you said, and maintain it and get an effect there, and then you have other things in your back pocket that you can do in the future.
Yeah,
I think one of the great advantages of this technique.
Okay, so I don't know, maybe this is your video.
This is not.
It's not your video, but we'll
it's
talk
not
about
my video,
the Trypan Blue.
But I was going to say, I would have taken credit for it, but the name was already of the surgeon. I would have tried.
Okay, why don't you run us through this video?
Sure.
It's probably similar to what you've done.
Yeah, so anyways, you can see, and this is
This is the original.
Yeah, old school. I used to, when I'd watch this, I would literally probably walk out of the room because I'm like, I will never be able to do this. Is like so delicate and so complex. Now with the tech, having the ability to have an ab interno in an injected system is amazing. But you can see this blue dye leaking into, basically into the anterior chamber and blowing open that trabecular meshwork. You can also see it going downstream with a blue tint in the collector channel. So they'll zoom in on that.
Yeah, you can see it right at that limbus, the blue, and then a reflux back in as well, implying that there's kind of flow across that.
That's right. So that's a great demonstration. I do prefer operating out of the paracentesis. I actually do it at the beginning of the case before I've done my main incision. And what's great is you have this closed system, the eye's filled with viscoelastic, and then you're putting this through a paracentesis, so you don't have any backflush, out of the main incision. The chamber doesn't collapse, and just operating through that paracentesis allows for a very controlled environment.
Yes.
I also I think it allows it to kind of, when you're injecting the viscoelastic, it allows it to push, I think, a little bit more effectively, to open up those channels.
Yes.
Working in that closed system, and so I like the fact that this paracentesis. And you're not dumping viscoelastic, or the chamber's not collapsing.
Yeah.
I think it makes it.
I think that's a really beautiful way to do it.
Yeah.
I happen to make a main wound and do it at the end. I've done it both ways.
Okay.
I just always like to get the cataract.
No, I hear you. There's something to be said for that.
So here we are. I mean, this is basically, we're going to talk a little bit about the actual handpiece and the injector and some surgical tips for that. But this is basically the original iTrack microCAD, was used in 2008.
Wow.
Then that required a little bit more cumbersome activity, so I avoided it, as did you. And I'm a glaucoma specialist, and I was like, that's good, I'll do something else.
Right.
But then when the handpiece changed and it became more user-friendly, I switched over, and I love it, actually. So let's see here. So iTrack Advanced here, as we noted, it delivers 100 plus microliters of OVD, and it's 360 catheterization, and it is titratable. So if you wanted more or less in an area, you could do that.
Yes.
One thing I will say that I noticed, and I had some advice given to me, is that when I did this once, it actually, at one point, didn't advance at all. After like 2 clock hours. And I'm like, I don't know. And I tried, and it kept wanting to go down. So I thought that there was an obstruction there.
Sure.
And one piece of advice was to actually turn around and go the opposite way.
Yes.
And if you do have an obstruction there, then now you've opened up the rest of the way up until then, going the opposite way, allowing it to function again.
Yes, totally agree. I had the same thing. One of my earlier cases, I got an obstruction, or maybe it was going down another path. I could just tell it wasn't going properly. And so I came back out, I had the paracentesis already made, and where I usually use my second instrument, use that to access, and the device is well designed, so you can turn the tip either for right-handed or left-handed approach, and had that ability to go back in. And it went 360 degrees, and I knew when I was getting close to that point, I was wondering, okay, am I going to hit the obstruction or not? But I was sort of preloaded or pushed some viscoelastic, sort of opened things up, and it came all the way 360. And so they have the ability to go both ways. Ideally, it's nice, just to have it gone one way, 360 degrees, one incision. But knowing you can do both is
and if you have an obstruction, you can just bypass it and go the opposite way.
That's right.
So that's good. Okay, we've talked about that. I think the illuminated tip is probably the most favorite part of this, because you can see where it's going. I think this might be my video. It is, So here I advance the catheter tip just to test it, make sure it's doing that flawlessly. And then again, I use some visco elastic, and then I show the paracentesis. You kind of want to aim, if this is 12 and 6 o'clock, right around the 6 o'clock mark, aiming up towards that angle. And then advancing with the tip kind of aimed a little bit more at an angle, 35, 45 degrees up, so that you have it going into the right space instead of aiming down. And then you see the advancement of the the red light, and you see it go all the way around. It meets. At that point, I usually ask my scrub tech to prime it a little bit more, 1, 2, 3 clicks. You'll see sometimes that viscoelastic come out. And then a very slow deliberate movement. I say one, she repeats one, and we go back and forth about 36 times.
Oh,
So
I like
36
that.
seconds, so that we get this like really slow movement across. And I say that because we're always in such a hurry to finish a case.
Yes.
But this, it's just 30 seconds.
Yeah.
But it's like, it allows you to, you know, you can see it coming back around. I'm probably saying 34, 35, and then 36, and then you retract it all the way back.
I like that verbal back and forth,
Yes.
because I usually just say one and I'm listening for it to click, but
Yeah.
it doesn't always click.
Oh,
Sometimes you
yeah.
don't hear it, but I like.
We see that blanching.
Oh my God, that's
you see
amazing.
it's super white. This
Yeah.
was before the case, and this is after.
Yeah, I mean,
and it's really
that's an
incredible.
obvious effect. I mean,
Yeah.
you know that.
Something is going somewhere.
Yes, yes.
You know that something's being opened up.
Yeah.
That's kind of my technique for
Yeah.
doing it.
Yeah, out of any surgery that we do for MIGS, this is like one of the most satisfying because you have that immediate tactile feel.
Yes.
You know you've done something. You
Yeah.
see this immediate effect. You know that patient's pressure is going to be good that next day.
Yes.
And so you can feel confident. Some of the other MIGS, like, I don't know, for example, for me, for SLT, when I'm doing it, you don't really see anything going on. You see a
Yeah.
couple of bubbles. I'm like, did I do something?
I know.
Is something happening?
And then you look at it a few weeks later and you're like, oh, hopefully this worked.
Yeah. This,
That's right. You see it.
Yeah, you see it.
So patient selection, any advice? You know, I know that you are big in refractive and
Yeah.
cataract and super healthy eyes.
Yes.
And you know, I see a lot of more diseased eyes as well. But what
Yes.
are some of your patient selection criteria when you see these?
Yeah, I
when you
mean,
do
for
this?
MIGS, I like to offer this as a first line treatment. Well, when I say first line, anybody that's having cataract surgery and has glaucoma, I think it's a must to offer MIGS procedure. And I think this has been, since the day I've used it, now I've used it on every one of my patients that's having cataract surgery and glaucoma. We also offer it standalone. So let's say if somebody's been pseudophakic, maybe they had one eye done years ago before we had MIGS, and now they come in for the second eye. We do this plus cataract surgery. They get a great effect. And they're like, well, doc, can you do my other eye?
Yeah.
And we'll go back in and do a standalone treatment. And we've seen great effect that way as well. So pretty much any patient with mild to moderate disease, and even severe disease, I think this you might not get the same effect, but I think it's worth a try.
Yeah.
And
And oftentimes I think the severe ones have a more stenose.
yes,
And so it may or may not work, but I absolutely think it's worth an effort.
That's right.
To do that for these patients.
That's right,
And to utilize one more avenue to help these patients
Yes.
either lower their pressure, get to target, get
Yeah.
off a drop, anything that will help their quality of life. All of
Yes.
those things are reasons for me to select them for this procedure.
that's right. Totally agree.
So let's see. Is the iTrack Advanced procedure difficult to master? I guess I'll ask you this, and then you can ask me the next one.
Okay,
How
sounds
does that
good.
sound? So do you think it's difficult to master?
I think as for the MIGS procedures, it's one of the easier ones. A number of reasons. It's relatively straightforward. You have an easy, sort of injector tool, very thought out. It's got the tracking light, so you know where you are. You're basically, outsourcing the viscoelastic delivery. Somebody else is managing that, so it frees up a hand.
Yeah.
I work with fellows,
Yeah.
and the fellows have adopted this very quickly.
Yes.
Some of the other devices, I get a little more anxious
Yeah.
as far as integrating, but this device is very easy to teach and adopt. So to me, it's a no-brainer. I think
Yeah.
it's safe, effective, and easy learning curve for sure.
Okay, I
Yeah.
agree. I
Yeah.
agree with you. All right, I guess you have to ask me this
Okay,
one.
so should the iTrack Advanced procedure be performed prior to or after cataract surgery?
Well, that is personal preference,
That's right.
I've actually, my first couple I did prior to, because I was eager to get to the
Yeah.
procedure and just understand it in an eye that had a really clear cornea and it was like well formed. So there's definitely an excuse to do that, a good excuse to do it before cataract surgery. It has, nothing has really changed. I like it after. You do get a little bit more angle opening,
Yes.
even though you can viscodilate that area up. I like to get the cataract out of the way, so I prefer it afterwards, but I switch it up depending on how I feel about the eye.
Sure.
If I'm doing on an angle that's really kind of more tight and narrow, I'll do it afterwards.
Yeah, that makes sense.
Yeah.
You're right. And it just depends on what's presented. I think that's a good way to look at it.
There's no right or wrong answer on this one.
That's right.
All right, let's see. Will adding iTrack Advanced to one's surgical protocol in any way diminish what was done during the cataract surgery? That's your...
Yeah, no, I think this is an easy no-brainer by adding this on. You're not, the risk profile is not being elevated with this. I've not had, thankfully, I haven't seen any adverse events with use. I think that, I'm trying to think of other procedures that might have a higher risk of, let's say, hyphema or bleeding. With this, I think it actually decreases because you're getting this viscoelastic in the channel. It's almost tamponading anything going on. So let's say if you happen to be doing a stent procedure as well, in addition to this, sometimes a stent can bleed. And I've noticed when I'm combining a stent with this device that actually I'm getting less heme in the anterior chamber because we filled the canal with viscoelastic to tamponade everything. So to me, it's actually the same risk profile as cataract surgery alone, and definitely lower risk than a lot of the other MIGS devices.
Yes. Anytime I have a combination procedure, cataract and a MIGS, I do a lot of consenting on the hyphema potential, and the vision might be blurry. And a lot of our patients are, refractive still. They see really well, and you don't want them to have blurry vision. And with this one, I do have a little more confidence that they're going to be pretty good the next day. They're not going to have this hyphema associated with like a goniotomy or that reflex heme that we sometimes see. I mean, it's not impossible. Of course, it can happen, but it's a lot less in my hands.
I agree.
Where do you position iTrack Advanced in your treatment paradigm? I think that's my question.
Yeah. So what do you think?
So for me, it is a patient who is mild, moderate, or severe disease, a patient who is on glaucoma drops. I have to think about doing something for them in the OR at the time of cataract surgery. I think gone are the days where you just say, no, I'll save this for another time. I think you're doing a disservice for patients, truly, if you're not actively trying to help them with the glaucoma at the time of cataract surgery in some way. So patients who are on drops, I evaluate them and I say, we're going to do this combo procedure. Maybe I can get you off of a drop. And some may argue, well, they were perfectly happy with the drop. Others may argue they were probably never using the drop. So there's a lot of really good arguments to implementing this on patients and thinking about any patient who has RNFL defects and visual field defects. How can we make their life a little bit better?
Yeah, I totally agree. I think you can even see it on these cases that eyes with glaucoma, if they're using drops, they have hyperemia. A lot of them are allergic. To get those patients off that drop. And that toxicity and the dryness that can cause all those things. I think if you have an opportunity to make an intervention that can help decrease the potential of using drops, I think it's a no-brainer. And I tell patients, the drops may be working now, but we don't know if you're going to lose effect, if you're going to get allergic to the drops, if your insurance is going to stop covering the drops or whatever it might be. There's unknowns in the future, and if we can make an intervention at the time, I think it only makes sense.
I think so. We agree. We have the same philosophy on this. And then what outcomes can we typically expect with iTrack Advanced? I'm getting, good IOP outcomes the next day, the next week. Again, I've used this short term. I think we all need to have more data.
That's right.
That's been clear always. We are data driven.
That's right.
So we keep doing this and we create studies and allow for more data to be developed so that we can actually answer this question with like pure confidence as opposed to, my hands, they're great. My patients are sometimes single digits the next day.
That's right.
And it's unusual that I see that. I get kind of, happy about that, So, but I'm going to kind of monitor my own results and see how they're doing long-term, 6 months, a year, 2 years.
Yeah, I totally agree. My experience is very similar. I think that we're seeing this immediate day one decrease in pressure. And if you think about these patients that have cataract surgery and glaucoma, those are your high-risk pressure spike patients anyways. And to offer something on the table and have that immediate effect, we've basically eliminated those day one pressure spikes, by through this intervention. So I've been impressed on the an immediate result. And like you said, we're going to need to track it long term
Yes.
to understand what sort of durability the procedure has.
Yeah.
But I'm impressed in what it's done so far.
And I think since this is the newer generation of this, and it relatively came out this year, it's our responsibility to like really like move forward, get data, and get this into people's hands again.
That's right.
Speaking of data,
Yeah.
that was a good segue. I didn't realize that.
too.
But this is some of the real world data showing the decrease, the pre-op IOPs in the high teens coming down to the low teens for these patients, and then IOP reduction from 2 to 1 meds depending on which of the studies that you see. But overall, you see a reduction in pressure and medication use.
Yeah.
Anyways, I think this was really awesome. Thank you so much.
Thanks,
That was
Sahar.
awesome.
Yeah, thank you. Yeah, good to see you.
Thank you guys for listening.
Thank you.